Okay. This is going to be a bit more philosophical. Of course, what is the contribution of surgery towards improving the staging system? I would say the joint contribution of low-dose CT screening and surgery towards improving the staging system. As you know, you get specimens from surgical procedures, and then you get the pathology, you get survival curves, and these are used to build T categories, staging categories, and then in turn the new staging will influence subsequent therapeutic choices. So this is a slide that tries to summarize a long story that started on the left.
How do
you see in the early 90s, okay. Lung cancer screening started in Japan, where they saw that there were tumors that could not be seen on a chest X-ray, but would appear clearly on a CT scan. And in the following years, we had the first publication of the I-ELCAP group. And after that, the Noguchi classification of adenocarcinoma that showed that there is a spectrum of aggressiveness for these tumors, which is reflected by the radiographic appearance. In 2011, a new classification, histologic classification, that dropped the denomination of BAC. It's no longer called like that. And in the meantime, several years later, a lot of data were accumulated that finally led to the new T descriptors that take into account that for subsolid lesions, what counts is the solid proportion. So, and you can see this. Okay, the classification is robust enough, and there has been no change between the 8th and the 9th edition. So we just move on from that. For those who are not familiar with surgery, I thought I would just summarize what we mean by wedge resection, which means you just cut a peripheral portion of the lung without any attention to the internal anatomy. While if you want to do a segmental resection, then you have to find, isolate, and transect all individual vascular and bronchial structures in order to have complete clearance to the hilum, but without sacrificing a whole lobe, so saving the most possible functional lobe, lung tissue. Lobectomy was the standard of care until not long ago. But we go back a little bit, it became apparent that these subsolid lesions behaved in a more benign way, with very little tendency towards nodal metastasis and very good survival outcomes. So for the first time in 2012, it was acknowledged that maybe sublobar resection would suffice for such tumors. Although still lobectomy was considered the standard treatment for most lung cancers. But in the meantime, it was, as I said before, noticed that the solid component was more important than whole tumor size. It was more predictive of nodal metastasis, of long-term recurrences and outcomes. And this was confirmed again and again. So someone started thinking maybe wedge is not enough. We do segmentectomy, which is more complicated, but maybe will yield better results. So far, so good. We have come to the JCOG 0802 trial, which proved equivalence, oncologic equivalence between sublobar resection by segmentectomy and lobectomy. Actually, even better if we think about overall survival, because of reduced all-cause mortality. So same number of recurrences, a little bit higher recurrence rate, local recurrence rate, but overall same, but less mortality for competing causes. And then we have the CALGB trial, which is a bit different. 58% of the cases were done by wedge resection. So we can only account for 150 or so segmentectomies to compare with lobectomies. Apparently, the results are equivalent for 2 centimeter peripheral tumors, but these results do not seem to be replicable in real life. You see, this is very recent publication from registry data showing that you see in the right hand upper corner, the red line is the wedge resection. Segmentectomy and lobectomy are grouped together, but wedge resection yields inferior results. So there may be some quality issues with wedge resections that lead to higher recurrence rate, and there has been an attempt to standardize how wedge resection should be done, because what counts is you get clear margins. And this is very quickly our experience in Verona. We've done so far 120 segmentectomies, and with very good outcomes perioperatively. And technically speaking, segmentectomy, you need to locate a lesion, which is sometimes small and not always so peripheral. So you either use this 3D reconstructions or multiplanar reconstructions. You can see the vessel going to the lesion, and you can count it, follow it towards the hilum to identify which vessels you need to isolate and transect. It's a good idea to mark the surface with ink so you will not need to look for the lesion again and again while you are transecting the parenchyma, and then you find the tributary vessels and bronchi, and finally you get a good sample. You get a good specimen with large margins, which is what counts more. This is important, especially as we have heard before, for multifocal lung cancer. Well, we know that the prognosis is governed by the tumor with the largest solid component. You would, for example, what would you do with this patient? You wouldn't go for a pneumonectomy. And in fact, we didn't. We went for 2 segmentectomies in the same procedure, on the same operating session. But because we know they tend to be indolent, it has been known for a long time, so maybe observation could be acceptable. It has been repeated again and again, and sometimes we use this. If the patient is reluctant to undergo surgery, we don't push a lot. You can see this patient has been stable for 5 years, but maybe she knows that one day maybe she will receive surgery, but no hurry to be for the time being. Whether this is safe is going to be explored in a number of observational studies. This is one, but there are more in Japan undergoing. So, as I said before, there is a collaboration between surgery and the low-dose CT screening in order to get data, to inform and to change the staging system. I have to say you wouldn't get this data if you had SBRT for everybody. You need the pathology. And last but not least, I have to mention low-dose CT screening was a major factor that promoted minimally invasive surgery, either by VATS or RATS. And also it prompted the refinement of nodule management protocols, because you have a lot of unwanted harm, not a lot, but you have some futile resections in any lung cancer screening study. These data can and have been used to reduce the number of futile resections also in current practice. And you can see in our own practice, this is unpublished, but the number of futile resections is down to 2.5 after the implementation of screening-derived nodule management protocols. In the beginning, we were just resecting anything, but then we learned we shouldn't. And I think this is it. Thank you.